We know that bleeding rates following PCI vary markedly among hospitals, but we're here to look at the extent to which use of bleeding avoidance strategies explains these variations. And to do that, I'm with Dr. Amit Vora, who is an MD and an MPH and from Duke Clinical Research Institute at, of course, Duke University Medical Center. Now, the impact of bleeding avoidance strategies and their effects on hospital bleeding rates, what got you interested in this topic?
Thanks so much for having me, Rick. You know, to tell you the truth, periprocedural bleeding following PCI is the most common complication. And it's associated with significant both short and long-term morbidity and mortality. And so over the years, people have developed a number of bleeding avoidance strategies to try and mitigate this risk. And so examples of bleeding avoidance strategies include transradial access, targeted anticoagulation with bivalirudin, and potentially the use of vascular closure devices following the PCI. And so what we wanted to look at, we also know that bleeding, as you mentioned, sort of varies markedly across hospitals. And so we were particularly interested in the extent to which the use of bleeding avoidance strategies explains this variation between hospitals.
This is NCDR analysis, and NCDR allows for really big data analysis. And in this case, you used the Cath PCI registry to determine bleeding rates among almost 2.5 million procedures. Good grief, there's some computer power. So what did you find?
Well, so, I think you're exactly right, that NCDR, and I think it's a testament to the NCDR that they're supporting registries like Cath PCI. I mean, it is the largest quality improvement registry for PCI in the world. And, for this particular registry, we capture information from more than 1,500 sites across the United States. And so we found that when we compared patients that had bleeding and didn't have bleeding, the patients that had bleeding was about 5% of the overall population. And some of the things are kind of what you would expect, that the patients that had an episode of bleeding were more likely to be female, were more likely to present in extremis, so were more likely to present with an ST segment elevation, myocardial infarction, and cardiogenic shock, were less likely to have radial access, were less likely to have targeted anticoagulation with bivalirudin, less likely to have vascular closure device use. The interesting thing was we created a series of fixed effect models to try and explain this variance. And the overall, so the median hospital had a bleeding rate of 5%, but there was also a significant proportion of hospitals that had bleeding rates in the 8, 9, 10% range as well. And so when we created our models, we found that patient risk, so after adjusting for patient risk, that explains about 20% of the overall variation. After that, the use of bleeding avoidance strategies tends to be somewhat incremental. So our best model was after adjusting for patient risk factors and then adjusting for radial access and bivalirudin. And in total, it explains about 26, 27% of the overall variation in bleeding rates among hospitals. And so what that really tells us is more than 70% of this variation is unexplained.
So what can we do to determine the causes of that remaining 70%?
Well, so I think it's two things. I think this analysis first highlights the need for more granular data collection, and just sort of better information about best practices and implementing best practices across hospitals, specifically from the places that have very low bleeding rates to the ones that have much higher bleeding rates. I think more broadly speaking, though, there is a concern that periprocedural bleeding would be a useful quality indicator and tied to things like reimbursement, et cetera. I think that our study advocates caution on that front, primarily because if so much of this variation is unexplained, it's not really clear that there's a path forward in terms of aggressive quality improvement. And so I think our study really advocates the caution in using periprocedural bleeding as a quality indicator, but then also highlights the need for more granular data collection.
So are you going to do any of this analysis yourself? Do you have anything else planned?
With my partners at Duke, with Sunil Rao, and as well as my partners with the NCDR and at ACC, I think that bleeding is an incredibly important complication. I think we're trying to do everything that we can to minimize rates of bleeding following PCI. So
It's an important topic and one I'm sure we're going to talk about in the future. So
absolutely.
Thank you very much. We have something like 24 papers from NCDR being presented here at ACC 16. We have summaries from a lot of that in CardioSource World News and CardioSource World News Interventions.